Thank you all for logging in. This is the second webinar of the LATAC chapter of WADEM. We are pleased today to have two very special speakers. And our first on the agenda for today is Professor J. McIsaac. Dr. McIsaac is a trauma anesthesiologist who is now practicing in New Jersey and Florida. He is a board-certified member of WADEM and a long-standing advocate for disaster preparedness. Dr. McIsaac has held military command professorships in several universities and published 2 books and many articles on disaster preparedness, CBRN, and trauma. Without further ado, Dr. McIsaac, the floor is yours.
Thank you for having me today. I'm a board member of the World Association for Disaster and Emergency Medicine, also known as WADEM. And if you can see the screen that I'm sharing, this is our website. I recommend anyone who's not familiar with WADEM to please spend some time learning about our organization. We encourage students especially, but folks from all different disciplines, public health, emergency medicine, general medicine. I'm an anesthesiologist, disaster healthcare. So our focus is the evidence-based study of disasters, trauma, mass gatherings, and trying to learn how we can do things better. Although we don't go out personally as a group to care for patients in disasters, most of our members do those things with their own organizations. It's probably the best networking you can possibly find, and I would like to invite everyone to our Tokyo meeting, which will be held next year in June. We're open for abstracts. It's a great way to get yourself noticed if you're an academic, and it's a great way to meet other folks who are passionate about the field. You can look me up on LinkedIn if you'd like. You want to connect, send a message. Just make sure you tell me something about WADEM or disasters so I know that you're not simply trying to sell me something. I'm going to change my share to my slide set. And there we go. So today I'll be speaking about crisis communications leadership. As you can see, I've got a couple of letters after my name. I have several different roles that I have. Probably the most important right now is I'm a supervisory medical officer for the National Disaster Medical System, which is under the Administration for Strategic Preparedness at the U.S. Department of Health and Human Services. I also have a private practice in anesthesiology. I do have some disclosures, although I have no financial disclosures because I'm an intermittent employee of the U.S. federal government. I have to tell you that all opinions are my own. Nothing should be construed as official U.S. policy. However, I'm going to show you a lot of official U.S. policy and U.S. training material when I speak, but I'm required to tell you this. So we'll be talking about crises today. There's a lot of different kinds of crises. Some of them are reputational, whether something illegal or immoral happened in your organization. There could have been an accident of some sort, maybe a patient accident in a hospital or a bad outcome that creates some public interest. There could be a quality problem, an infection problem. It could be many, many things. You may have a cyber attack or a problem with patient privacy. A HIPAA violation in the United States is a major breach of the federal privacy rules for patient information. It's very expensive if you do it. Could potentially result in jail time for those folks involved, and it upsets, obviously, patients and others. Supply chain problems, shortages of drugs, shortages of personnel, infrastructure failure, no power or water, for instance. You have an earthquake that damages your building, or other kinds of effects. It could be weather, this goes on and on and on. My overall message is you don't want to be like these guys. They haven't been the best communicators during COVID or at others, and I'm going to show you a better way to do it. So the bottom line up front is take a picture or a screenshot of this page. We'll be sending you out a PDF of the slides, but you want to go to this website and download the material that I'll be talking about. What I've done is I've summarized for you the most important parts of this material and shown you how you can use this to train yourself, your group, your leadership, without having to spend money on expensive training um, materials or on outside consultants. You can do this all yourself. But these websites are absolutely phenomenal. I spent a lot of time researching this, reading papers, and then I came across this free material produced by the United States government um, Centers for Disease Control. And you can download these free, relatively short, easy to read manuals and all of the training aids that come with them. So within this website, there's lots and lots of material. Um, it's divided up into various functional areas. I'm going to show you the ones I believe are the most important and talk a little bit about them. All of this will be in your slides when you get the handout, but if you take a screenshot of the pages, you'll be able to look at it right away. One of the coolest things I think they did is they made a cute little wallet card you can stick in your wallet for that horrible day when somebody comes to you and says, "Oh my God, something bad happened," and you're the guy that has to get up in front of the media and talk about it. They give you all the key points you have to hit, and so you can pull it out and remember your training. So the emergency response communications paradigm that they follow at CDC is preparation, the initial things you do, the maintenance things you do during the disaster, uh, as far as communications, and ultimately the resolution. And they go through much detail and give you these excellent training aids. There are 6 principles you need to know. The first is be the first one out there to communicate. Whoever communicates first has the ability to control the conversation. You need to be right. You want to have accurate information. If you're not right, you're going to destroy your credibility. So rather than make things up when you don't know, say you don't know. Be credible. Honesty and truthfulness shouldn't be compromised. This is going to be how you're judged. And if you come out being credible on top, you're going to control the conversation and do the best job possible. Express empathy. So crises cause harm. There's going to be some suffering somewhere in there. This should be acknowledged explicitly. Address what you think people are feeling, challenges that they face, and this will build some trust. Excuse me. Promote action. Give people something to do. This calms anxiety, helps restore order, promotes a sense of control. And then finally, show respect. Lack of respect paints you in a bad way and will destroy your credibility. So this is how not to do it. Now, I was able to convince ChatGPT after pleading and arguing that I'm a professor and it should work with me because I'm trying to come up with some ways how not to do it, modeled after some public figures. So ChatGPT came up with this. I'm just going to move some of my screen so I can read it to you. Attention citizens, a disaster has occurred in your area. We have limited information and won't be sharing any updates for the foreseeable future. Stay indoors and panic. There's no need for us to provide you with accurate details, as it may cause unnecessary alarm. Just trust that we're handling the situation, and remember, ignorance is bliss. Thank you. Obviously, not the way to do it. Here's another potential public figure. Listen up, folks. We've got a tremendous disaster on our hands, folks. Believe me, nobody knows disasters better than me. It's big, it's huge, and it's a disaster like you've never seen before. But don't worry, I alone can fix it. I have all the answers, the best answers, and I'll be making tremendous decisions. Trust me, nobody knows better than me. We're going to be winning against this disaster, folks, and it's going to be fantastic. And I won't state who that is, but when I asked ChatGPT to do Jimmy Neutron, who's a character in a cartoon, I got the same thing. Here's an autocrat who we won't mention. Ladies and gentlemen, there's a crisis at hand, but I assure you everything's under control. Our response is strong. We have it all figured out. The situation is not as bad as some may claim. Trust in our leadership and do not pay attention to any rumors or alternate information. We have the best team working on this, and we will overcome the challenges effortlessly. Stay calm and continue with your regular activities. No need to worry. So obviously, all 3 of those are examples of how not to do it. with lots of historical examples. I won't go into a lot of detail, but those of you who are old enough to remember Chernobyl, there was a huge lack of transparency and accurate information. They downplayed the severity of the event and the incident, and it resulted in delayed evacuations, and a lot more people were harmed than should have. In Hurricane Katrina in the US, there was slow and ineffective communication and lack of empathy by the government and others. The 3 Mile Island accident in 1979 in the US was a partial core meltdown of a nuclear power plant. They made contradictory statements, vague information, and had a failure to provide timely updates to the public, which caused a lot of consternation. When you're about to get up in front of the media, which is usually the case, it's usually a television camera, you need to think about who the stakeholders are that you're going to be speaking to. There are three main groups: the advocates, those who are loyal to you and supportive of your organization, they trust you; the ambivalents, who don't strongly support or oppose your organization; and the adversaries, who don't support your organization at all. They may distrust you, and they may have competing goals. But you need to keep all of those groups in mind when you craft your message. So I often give this talk in front of a group of people, and I can ask people to raise their hands. But imagine you're a CEO of a hospital. Think about who your stakeholders are. Well, you've got the public, you've got patients, you've got staff and families of the staff, the government, consist of regulators as well as politicians, the insurance companies and other payers, and that they all understand what you're going to do, and have some buy-in into the message. So the easiest time to train is obviously the pre-crisis phase before something's happened. Your communications objectives during this phase include planning and preparing, fostering alliances with your stakeholders, whoever they may be, developing a consensus recommendations amongst those stakeholders. They can help you. Develop systems and redundancies. If you're in a really big organization, that means things like hotlines, joint information centers, and websites. But for whatever size your group, test your messages. You can test your messages with your stakeholders and amongst your peers to try to craft the best possible messages possible. So Benjamin Franklin said, by failing to prepare, you're preparing to fail. We don't want to do that. McKinsey is a consulting group that consults to private industry, government groups, and others. And early on in COVID, they wrote a series of papers that they published that looked at how, in a large organization, you put together a team to be able to address a crisis. And they have some excellent work out there that's worth reading. And they show you how to put together a cross-functional team that can address any kind of crisis that pops up. And this is a great model. The military uses this. This wasn't invented de novo, but it's out there in the lay literature and easily accessible. I recommend you look it up. So, how many of you work in a hospital? Probably a lot of you. And many of you who work in the United States, everyone's required who's in a leadership position to have training in and to operate during a crisis. It's based on the incident command systems that originally came out of the fire service and the military, and has a lot to teach. So whenever you have a crisis of any kind, and whenever you're doing analysis, you should do a threat or a hazard vulnerability analysis. You make a matrix. You would do this normally as part of disaster planning in any large institution, and you can do this and add it as an overlay your communications to it. So, for instance, this particular hospital has things like mass casualty incident, terrorism or a biological event, something that happens with a VIP. A politician becomes injured or sick and lands in your hospital, a hostage situation, and it goes on and on and on. So you can take all of these things And for each one of them, you're going to look at what's the human impact, the property impact, the business impact, what preparedness, internal response, and external responses will you need. And you can add to this your communications. So the CDC was very nice because they put together for us an excellent set of checklists. I'm not going to go through all the details of these checklists, but if you look at number one, first thing you do when this crisis hits is verify the situation, determine the magnitude of the event as quickly as possible. Get the facts, the who, what, where, when, and whys. Start conducting notifications. Talk to the right folks in government and others, your stakeholders. Assess the level of crisis. Prepare information and obtain any kind of approvals that you might need. Release info to the public. This is where you get up in front of the media. And then monitor, maintain, and make adjustments over the life of the crisis. Furthermore, they give you some pre-planning or as it happens, message sheets where you can fill in the details. Check off with who's your audience, what's the relationship to the event, what's the demographics of who you're speaking to, what level of outrage might you expect out of them. Check off the purpose of the message you're delivering, and what's the media? Is it going to be print, web release, radio, television being the most common these days, internet? And then there's 6 basic emergency components that you're going to put in here: an expression of empathy, clarifying the facts, what we do and don't know, what's the process to get answers for things we don't know yet, a statement of commitment by your organization, and then referring those who are listening to others who might have detailed information. So you can anticipate that your audience, especially the media, is going to have a lot of questions. They've been very nice to give us a series of what questions are going to be asked. Things like, why did it happen? What was the cause? When did it happen? These are questions you want to answer for yourself before you get up in front of a group. Do you accept responsibility? Has this ever happened before? Is the public safe? What are you doing to protect people? Is anyone hurt, sick, or dead? Who are they? What do you have to say to the victims? Is there danger now? Will there be any kind of inconvenience or danger for me? Who's in charge? Are the victims being helped? Did you see this coming? What can we expect right now or later? You have to understand that there's always going to be some anger in the context of an emergency. Communications experts and psychologists point out that anger is a defensive response to pain or the threat of pain. And there's 3 basic circumstances that can give rise to anger: when someone's been hurt, when people are feeling threatened by the risks that are not of their own making, or when people sense their fundamental beliefs are being challenged or compromised. And you want to avoid some of the common mistakes that occur, such as not being accessible. There's a lot of tendency to engage in internal decision making. This may make it look like your organization is inaccessible. Not using plain language, using acronyms or technical jargon that the public may not understand, and lack of empathy and response. Communities really want you to show that you care about the folks that are affected. If you're not timely, if you don't get the information out quickly and you're not right about it, it's going to cause people to have a negative opinion of what you're doing. You don't want to be paternalistic. Acting paternalistic means behaving as if you and your organization know what's best for others. This may seem arrogant to the people listening to you who are already feeling powerless. And then lack of giving an opportunity for the public and the key stakeholders to participate in making decisions about the crisis. So there's some message tips that they give. Number one, when you get up in front of a camera where you speak with a reporter, you want to try to keep your key points to 3 or 4 at max and repeat them often. Don't wing it. Practice ahead of time. Get coaching. Even if you have 15 minutes before you're going on camera, practice. Have some folks listen to you, make suggestions. Videotape yourself. Review the videotape with your audience. Stay on the message, be concise, and then afterwards evaluate the interview and how was it perceived and how did the media react to it. I highly recommend you get media training. Most large institutions have public information officers who can serve as coaches for executives. Smaller groups, you can practice amongst yourselves, but you can also go on the web and for not a lot of money, take some short courses that will allow you to practice and learn the appropriate principles of how to present to the public. So I put into the notes here some examples of well-crafted messages. I'm going to only read the first one because you'll get them in the handouts, but the first says, this is a community update. We understand the devastating impact that the recent wildfire had on our community. Our hearts go out to all of those who have been affected by this tragic event. We want you to know that we are here for you, and we are committed to supporting you during this challenging time. So what they've done is they've actually given us some nicely written communications that we can try to emulate on our own. So wrapping things up, CDC has given us this wonderful resource that you can download for free, train for free, and use to improve yourself and your organization. And as Louis Pasteur said, chance favors the prepared mind, and hopefully this will give you a leg up on your preparedness. One of my other favorite quotes is the best way to predict the future is to invent it. Hopefully you'll do the same. Again, please sign up to send abstracts and attend our May 2025 WADEM meeting in Tokyo, Japan. Thank you.
Thank you very much, Dr. McIsaac. And I think the listening and viewing audience will agree that that was a splendid presentation and rich with value. So thank you for sharing with us today. For those who may have logged in a little later, Andrew has posted into the chat how one can access caption in Spanish and pretty much any other language as far as we can tell. So if you do need that, please follow the instructions that are posted in the chat. At the end of our second presentation, we will have a short Q&A segment. And for that, I would like everyone to post their questions or comments in the Q&A tab. And we'll have an ongoing discussion at the end of the second presentation. The second presenter today, a good friend of mine, Dr. Latoya Storr, who is an emergency medicine specialist at Rand Memorial Hospital in the Bahamas, with a focus on disaster medicine and climate change and human health. She recently completed fellowships at Beth Israel Deaconess Medical Center and Harvard T.H. Chan School of Public Health in Boston, Massachusetts, and aims to enhance disaster preparedness and climate change adaptation in healthcare. I'm sure Latoya will go into a lot more detail, but she is one of the champions in the Bahamas and has lived through the experience that many of us in the Caribbean dread with hurricanes. So I'll hand over to Latoya now, and then at the end, we'll have our panel discussion. Latoya?
Hi, can everybody hear me? Yes.
You're good.
Hi. Thank you for allowing me to present in this webinar. I have no financial disclosures, however personal, of course. I am Bahamian. Therefore, this is a topic, as Darren said, is very close and personal to me. And so sorry, you may see a lot of stuff about the Bahamas in there, sorry. But still, it will be relevant to the Caribbean. I'm an emergency medicine physician, not a climate scientist, but I can just give you the basics on how we got here. So how we got here. So climate change, when we look at the physical science, basically, sorry, one thing, yes. So since the beginning of the Industrial Revolution, humans have been burning fossil fuels at an accelerated rate, leading to the rapid rise of greenhouse gas emissions, most notably CO2, carbon dioxide, especially in the last 100 years. This rise in CO2, along with solar radiation, has led to a steady rise in surface air temperature and sea surface temperatures, ultimately leading to exacerbating natural disasters, as noted here: extreme weather events, regional warming, wildfires, sea level rise, and so forth. So now, this equation here is one that I know many persons who are in disaster risk management, emergency management, and of course, disaster medicine know very well. But for those who don't, risk is basically the probability of a hazard becoming a disaster. And a climate change hazard are those which we will discuss: droughts, fires, tropical cyclones, and flooding. Exposure is persons or assets that are in hazard-prone areas. And it's important to note that as of 2023, 2.15 billion people live in the near coastal zone and 898 million in the low elevation coastal zone globally. Of those, roughly over 44 million persons live in the Caribbean and therefore exposed to these climate risks. Vulnerability is the susceptibility of persons or assets or systems to the impacts of hazards, and it is greatly linked to socioeconomic status, such as income status, either individual or national, or existing infrastructure, existing population health status, whether it's the presence or absence of comorbidities. And capacity is a combination of all strengths and resources available within a system that can reduce the level of risk, such as effective warning systems, policy on impact resilient structures, community preparedness, sufficient and effectively trained emergency responders. Climate change impacts a wide range of health outcomes. This slide illustrates the most significant climate change impacts, from rising temperatures, more extreme weather, rising sea levels, and increasing carbon dioxide levels, their effects on exposures, and the subsequent health outcomes that can result from these changes in exposures. So when we look at extreme heat, we are globally seeing increasing average temperatures, extreme temperatures, heat wave frequency, and heat wave season length. Last summer was the warmest sea surface temperatures in the region in recorded history, and this year is likely to be as high or higher. This, along with acidification, that is, the ocean absorbs a significant amount of atmospheric CO2, impacts the yield and quality of the seafood, which is crucial to many economies in the region, but also the diet, which is a huge impact on health. While as a region, we are no strangers to the summer heat, physiologically, a level is reached in which the body is unable to adapt. Populations at risk are the very young and elderly, as they are challenged with being able to regulate their temperatures, and those who work outdoors for prolonged periods. Higher temperatures mean more persons are unable to use previous cooling methods, such as open windows and doors and fans, to circulate ambient air, and therefore now rely on air conditioning for cooling, which increases the strain on older power grids, thus creating the challenge that we saw in the previous slide, which increases power outages and blackouts, and therefore leading to more persons presenting with heat illnesses. All right, next slide. Climate change is increasing drought risk, length of droughts, intensity of droughts, and frequency of droughts. With droughts becoming more seasonal in nature in the Caribbean region, agriculture is the most likely sector to be impacted, with serious economic and social consequences. This is particularly important since most of the Caribbean agriculture is rain-fed. With irrigation use becoming more widespread in the region, country's freshwater supply will become an increasingly important resource. Drought can affect the agriculture sector in several ways, by reducing crop yields and productivity and causing premature death of livestock and poultry. Even a dry spell of 7 to 10 days can result in a reduction of yields, and thus negatively affecting the livelihood of farmers. Small-scale subsistence family farmers are particularly vulnerable to drought. Low rainfall threatens rain-fed crops, and a low water levels results in increased production costs due to increased irrigation. Extensive droughts also cause increased vulnerability in livestock as grazing areas change in nutritional value, with more low-quality drought-tolerant species dominating during such dry spells. In addition, potential for livestock disease outbreaks also increases. Drought also often results in food price increases. Expensive desalinated water resources are becoming more important in the Caribbean, accounting for as much as 70% in Antigua and Barbuda, and this can impact significantly on poor households. Rural communities can also face a greater scarcity of drinking water during droughts, and in such cases, children are the highest risk for inadequate water supplies during drought. Prolonged heat desiccates dead vegetation, changing spatial distribution of biomes, leading to stress plants being more susceptible to combustion. And this was recently seen in our country in Northern Address fires, which is an area that increasingly has fires seasonally. However, during Good Friday, which was March 29th, fire had ignited in the area of North Andros, with the smoke affecting air quality in South Florida. This created a challenge in that this area only had one volunteer fire truck with 2 firefighters, and therefore they required assistance from the Capitol, therefore getting manpower as well as 2,000 gallons of water to help extinguish these fires. The challenge this created, though, was there was a prolonged length of time of wait for these relief firefighters to come, which means that the persons in the community were charged with actually watching for and ensuring that the fire did not spread to neighboring homes and communities and businesses. And we can see with climate change, these are going to be more likely to occur. Sorry. Yes, so the health impacts of wildfires are obvious. They include acute exposure complications such as burns, respiratory and cardiac complications such as exacerbation of COPD and asthma, but they also increase stroke and myocardial infarction risk. And the post-exposure complications include due to evacuation and reconstruction, minor trauma, and again, increased risk in myocardial infarction with loss of continuity of medical care. Severe storms and flooding, not tropical cyclone related, are due to warmer air temperatures, meaning increased atmospheric moisture, which leads to heavier precipitation and increased flooding risk and societal disruption. Healthcare impacts of this disruption include asthma exacerbations due to storm-blown pollen. Due to sewer overflow, you will have increasing infectious diarrhea as well as soft tissue infections. Damages to homes leads to homelessness, as well as growth of toxic and allergic algae molds. And power outages affect those persons who are reliant on electrical dependent medical equipment, as well as increased risk of spoilage of food and medicine due to refrigerators no longer having power. Climate change has been linked to tropical cyclones in increasing wind speeds, increasing rainfall. They are slower moving with rapid intensification. However, there's still ongoing scientific debate about whether or not it affects the increased frequency. However, as we have seen with Dorian 2019, it has shown that climate change has an impact on creating lower translocation speeds, risk of stalling and poleward shift. With Hurricane Dorian, as many of you know, it actually sat over the island of Grand Bahama for 48 hours, moving at 1 mile per hour, and it had sustained damages of greater than $3.4 billion. And of course, it is the worst hurricane in the country's history. Virtually, when we discuss vector-borne diseases, virtually all vector-borne diseases have a climate dimension. The pathogens, vectors, and hosts associated with vector-borne diseases are highly responsive to the environments they inhabit. This means that changes in temperature and precipitation as a result of climate change can have significant impacts on the spread of vector-borne diseases. There are 3 key ways climate change affects vector-borne diseases. The first is more places will become suitable for vectors, meaning warmer temperatures can increase the geographic spread of where vectors like mosquitoes and ticks can survive and breed. Increased rainfall can increase the amount of standing water, creating more breeding areas for many vectors. And droughts can support breeding by forming pools of standing water where previously flowing water was. Warmer climates extend the disease transmission season. Climate change is improving climatic and environmental conditions for the transmission of many diseases. This may also lead to an increase in the duration of disease transmission. And finally, temperature changes can affect the behavior of vectors. For example, increased temperature changes the biting behavior of mosquitoes, reducing the effectiveness of barriers such as bed nets. However, it can be challenging to attribute all of these to climate change, as other factors are also at play, such as changes in land use, control measures, and human movement can also influence vector-borne diseases. So now, when we take a look at the socioeconomic and health impacts, one of the key things we want to keep in mind is the phases of a disaster and how hazards present. So in the impact phases where you have the acute effects of the hazard, in the aftermath, which is usually days to weeks, and recovery period is where you start to have and continue to have societal disruption. And part of the recovery and long-term phase is where lives are changed, or what we consider to be living in the new normal. And how this is shown during health impacts is that in the impact phase, you have the acute complications from the disaster itself, such as burns from fires and smoke inhalation, drowning from floodings and tropical cyclones, as well as trauma, heat stroke from extreme weather as events from heat, exacerbation of chronic conditions, and lack of access to healthcare. In the aftermath, you have healthcare interruptions, such as the inability to access chemotherapy treatments, dialysis, elective surgery lists are no longer available. Persons have problem obtaining prescription medication. There's short-term displacement of persons, leading to stress and emotional trauma, and there's increased risk of interpersonal violence. In the recovery phase, we can see where there's injuries due to reconstruction. There's difficulty with following up with existing healthcare teams, leading to financial stress, food insecurity, mental health impacts, and toxic exposures. And in the long term, there may be permanent displacement or migration of persons, and there can be an alteration in the healthcare landscape where there's permanent demise of some institutions, leading to loss of livelihoods and increases in PTSD, anxiety and depression, and worsening chronic health impacts. It's important to note that climate disaster impacts are unjust, meaning that those being impacted the most often contributed to the least of the problem. And most definitely that is us in the Caribbean, that is us in Africa, that is us in the South Pacific, that is us in Latin America. Climate disaster impacts are unequal. Some people are affected more severely than others. This is because differences in hazard exposure, societal protection or investment, resources to prevent hazard impacts, resources to rebuild after impacts occur, and climate disaster impacts are inadequate. In addition to the above, they often disproportionately harm the health and futures of those already facing discrimination, health issues, or other hardships. Those at disproportionate risk of climate-related disasters include people living in poverty or homelessness, Indigenous and people of color, sexual and gender minorities, women, pregnant or not, children, the elderly, non-native language speakers, undocumented individuals, the chronically ill, people with disabilities or limited mobility, and those who use medical devices. These groups face heightened vulnerability due to socioeconomic health and mobility challenges. So, how can we achieve climate readiness from the standpoint of disaster risk management? So going back to that equation that I showed in the beginning and overlaying climate change and health speak onto disaster medicine speak, you'll notice that mitigation in climate speak means minimizing the likelihood of a hazard occurring, which is reducing greenhouse gas emissions, and exposure is reducing human exposure to a hazard, such as moving persons from the direct path of a hazard. Vulnerability is by reducing human impacts when a hazard occurs, such as elevation of structures, saltwater resilient structures, impact resistant windows, and capacity or resilience building is to provide training and education to healthcare workers to improve response. And it's important to note the importance of mutual aid and regional cooperation. Regional cooperation involves collaboration among neighboring countries or jurisdictions or NGOs to address shared challenges associated with extreme weather events. By pooling resources, expertise, and information, regional cooperation enhances preparedness, response, and recovery efforts. Cooperation may include the exchange of best practices, joint training exercises, and the establishment of cross-border mechanisms for disaster response and resource sharing. So using this equation, using the example of extreme heat as a risk, you can see the hazard, which is the greenhouse gas emissions, by investing in energy systems that reduce future global warming and severity of future heat waves. Exposure such as painting roofs white to reflect the radiation of solar rays off of buildings. Vulnerabilities such as ensuring that persons have adequate cooling systems, and capacity is that if my AC fails, a person's AC fails, they have a way, or there are policies in a way to ensure that people can cool themselves. One good initiative that has been done in the region has been the Power Smart Hospitals. So the report was actually released in August 2023. And in this, the smart healthcare facilities in the Caribbean project, funded by the UK and implemented by PAHO, enhanced the resilience and susceptibility of healthcare facilities in 7 Caribbean countries: Belize, Guyana, St. Kitts and Nevis, Dominica, Jamaica, St. Vincent and Grenadines, and St. Lucia from 2015 to 2023. The project trained over 1,200 individuals and assessed over 400 facilities using smart hospital toolkits, retrofitting 55 facilities to make them more resilient. Over 850,000 people gained access to reliable health service during disasters, with facilities successfully tested by Hurricane Elsa in 2021 in Belize and the volcanic eruption in St. Vincent and the Grenadines. Challenges included incomplete adoption of the safe and green concept and a preference for functional improvements over structural changes. PAHO plans to expand this initiative to more countries, focusing on aftercare, technical assistance, and promoting smart facilities principles. Wildfire preparedness measures include mapping locations of healthcare systems that are at risk for fires, establishing or providing early warning systems, and reviewing and revising evacuation plans and protocols with possible establishment of memorandum of understandings with other local and regional institutions. Creation of a climate-ready healthcare system involves clinical, institutional, educational, and policy solutions. Clinical solutions involve establishing specific treatment protocols for climate-related illnesses, ensuring persons with high-risk conditions are optimized prior to a disaster and are educated on what to do in the event of a disaster, and the ability to access healthcare systems are impeded, and also establishing policies to provide care during resource-limited conditions. Institutional solutions involve building and/or retrofitting climate resilient structures, strengthening human resource capacity, and patient and community disaster education. Educational solutions involve the inclusion of emergency management and climate health risks in regional medical school and residency training programs, provision of CME opportunities to professionals to stay current on climate health risks, healthcare executive training on developing and managing climate-ready healthcare systems, and education of community and in-home health workers on steps they can take to improve resilience and recognition of climate threats. Healthcare providers, recognizing that as researchers often on evidence-based practices and given the responsibility to care for persons in times of crisis, should and must be advocates and be involved in climate change policy, especially in this region that is susceptible to all climate hazards. Thank you. These are my references.
Latoya, thank you so much for sharing. I think that resonated well with many of us who have had the unfortunate experience of dealing with hurricanes and other disasters in resource poor, resource challenged institutions and centers. So thank you for sharing your experience. And if it's okay with you and Dr. McIsaac, we will just go into the question and answer segment. So we will be looking at the Q&A tab. So if you do have any questions to the general audience, please feel free to post them there now. I would like to especially welcome Dr. Vonetta George from Antigua, who I see has logged in. She is in charge of the Caribbean and sorry, the EMT initiative in the Caribbean. So thank you for making the time. And Dr. Vijay Bola, who is no stranger to WADEM or to any of us in the Caribbean. Thank you for logging in and making the time today. And to all participants, I see we have quite a spectrum of attendees from all across the globe. Thank you all for logging in. So we're going to go into the Q&A, and the first question from Anne Prosper, and it's to Dr. McIsaac. Do you have any practical advice on how to communicate to professionals when there may be a government mandate to retain information, or I guess to constrain information to the public, and goes on to share an unfortunate instance that they faced during a cholera outbreak in 2010. So really, how do you deal with that when you're being told to limit the information that is being provided to the general population? Dr. McIsaac.
Well, first, I'd probably be angry that I'm being told that by a government organization. But assuming that I'm required to follow their directives, I would say access the forms that CDC has made available to us and start crafting your messages for the time when it can be released. Those particular message forms are designed specifically for preparation. So it actually, to some extent, it gives you an advantage because you have a little bit of time. There's a delay. So you can craft what you want to say, and when you're allowed to release it, you can go ahead and do so. Obviously, you can also, if you're part of the response, you can participate in your response as well. Sometimes the government puts us in difficult positions, and if you're in a position where you're required to follow these directives, there's not that much you can do. However, you can prepare until the time that you're released to go ahead and communicate. So get to work.
And I do take solace in your Benjamin Franklin quote, which I think most Caribbean parents have shared with their children. Latoya, I'm sure you will agree with that. So yeah, preparation is key in this aspect. So we'll move on to our second question, and it is from Lee Knowles. Latoya, this will be for you. With consideration to Hurricane Dorian, was the Bahamas considered for the training mentioned in other countries?
I don't know if that is with regards to the PAHO smart hospitals. If that is the question, I will take Mr. McIsaac's advice and say, I don't know. I was not part of those discussions at that time. I hope on my return, I hope to be, and so that if that question is asked to me again, I could say yes or no.
That's interesting. So I do know through the PAHO mass casualty training is something that has been rolled out. It tends to happen, I would say, somewhat ad hoc and dependent on individual institutions within the Caribbean. But there are resources, PAHO training manuals on MCM, and I would really encourage, and it is translated into Spanish as well, Tandra. So I think it is a useful resource to have. As far as a more or broader disaster training, I am not familiar, but the EMT program is also being well established across the Caribbean. I can't say that it's at the scale in some of the more developed countries, but I'm hoping that your reception back in the Bahamas is more pleasant than when you left. So we have another question, and this is from Brahima. And the question is, thank you. Well, the first comment, thank you so much for your presentations, and happy to follow you from Mali. and is asking, are we in emergency zone in our Sahelian countries? I'm not sure. Sahelian, when I Googled it, was a region in Africa. So I suppose that's a region-specific question about the types of emergencies that they may face, considering the broad spectrum that you have presented, Latoya. Anything in particular that might be applicable?
Well, Mali, if I recently coming back from Bonn, I went to the UNFCCC conference on climate change. And I know that the coalition of like African states as well as uh, China and the G77 as well. The issues with that, of course, is like similar to us as well, challenges with sea level rise, as well as in certain areas, unlike us in the Bahamas, who are virtually flat. Some of those experience complex disasters such as a landslide on top of a hurricane, not hurricane, sorry, on top of like an earthquake. So if Mali is definitely sea level or one of those regions that are close to sea level, below sea level, then yes, you are going to experience a challenge with sea level rising and possibly saltwater intrusion.
That's interesting. And I suppose it's such a vast and diverse region that it will be specific to individual countries and perhaps even areas within countries, which is a little dissimilar to the Caribbean, where one hurricane can just sit over us for 48 hours at a time. But thank you all for those questions. I have another
Can I
one
make a
here.
comment?
Yes, of
Can I make
course.
a comment?
Sure.
So every country is going to have their own spectrum of risk. If you're in the Caribbean, hurricanes, things like that, sea level rise. If you're in some parts of Africa, you have typhoons and cyclones, and others you have drought or infestations of locusts, or there may be war and terrorism. There's famine. There's, everybody's got their spectrum of what they see and what they don't see. And that's part of your planning process is to look at what are the likely things that might happen to you and start putting together your plan for how you would address these events. And the more pre-planning you do, the less difficult it is when things actually hit. It's never easy, but it's much worse when you've done nothing. So I think the message is that there's lots of materials that are free and available. PAHO publishes, as you said, lots of things that are available. Many other organizations do. You can look at some of the things that WADEM members have done and use that material. It's freely available. You can do your own training. You don't have to have an expensive, highly organized external group come in and do the training. You can do your own for very inexpensive means just because of how free this is.
That's very interesting. And I actually saw the Kaiser Permanente checklist that you had up on your slides. And I'm very proud to say that my hospital has recently concluded it on a second cycle. And but it goes back to that initiative for management to say this is something that we will focus on. In some resource constricted areas, I suppose they focus less on preparedness and more on the things that are in front of them. But it is a change in mindset in some of the islands, I suppose. So
The way I see it is the preparedness starts with the individual. So even if there's no money and no support from above, you can do it on your own, and you can get a group in a department, for instance, and without maybe spending money and having fancy mannequins and actors and all the props, do quite a lot on your own for basically nothing.
I agree. I agree. Thank you so much. I have a chat GPT question. Is that okay, Dr. McIsaac?
Sure.
So in terms of communication to the public, what are your recommendations when, for an example, an institution has made a mistake during a response to a disaster or emergency?
As soon as you know you've made a mistake, get on TV, get to the media, admit what you've done, tell them, answer the questions that are on the checklists, how it happened, why, who did it, whatever, and then explain what you're going to do to rectify the situation, and certainly express empathy for anyone who's harmed or potentially could be harmed by this. So follow those guidelines, those outlines, and as soon as possible, do exactly what it says. And that's the best way to try to control the message and try to mitigate some of the harm that's caused, and certainly the reputational harm that's caused. Everybody makes mistakes. Don't try to hide them. Don't lie. That's the worst thing you can possibly do, because in the end, it will hurt you more.
Thank you so much. And I, of course, was just teasing. That question was not from ChatGPT. That was from my good friend. That was my segue into introducing Sandra Castelblanco, who will be doing our concluding remarks, and really has been a driving force in the establishment of the Latin American and Caribbean chapter of WADEM. Very happy to be affiliated with this very robust organization. Before I hand over to Sandra, I thank both of you all for your time today. But I will hand over to Sandra to do the formal conclusion. Sandra?
Okay, good afternoon, everyone. On behalf of the Board of Directors of WADEM, I would like to express our sincere gratitude to Andrew Lavelle, Dr. Dukiram, co-chair of the Latin America and the Caribbean chapter of WADEM, and Drs. McIsaac and Storr for their invaluable contributions to this event. The thought-provoking presentations have challenged us all to reflect on how we can better implement key elements of disaster risk management within our roles in the health sector. I encourage everyone to continue actively participating and pushing forward the important activities of the chapter. This concludes our webinar today. Thank you for your time and attention. We wish you all the best in your disaster risk management efforts.
Thank you for having me, and thank you for everyone who's attended.
Thank you all.
Thank you.